morning, everyone. Hi, ma'am.
You're prettier than what you look at the picture.
Thank you, ma'am. Thank you so much.
So, ma'am, we are on live, ma'am.
Yes.
Yes, ma'am.
Yes, Stalin. Good evening.
Yeah, ma'am. Very good evening, ma'am. Very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's TNFOG Marathon CME. Today's topic is only tubes. I welcome all the speakers, chief guests, and the participants who have joined here in this evening. And let me take my pleasure to introduce the secretary of our TNFOG, ma'am, Dr. Professor Sambat Kumari, ma'am. Madam is the VP elect 2022 for FOXY, founder secretary TNFOG, and Madam is currently associated with Muthukumaran Medical College as chief and HOD of OG department, and Madam is holding various posts as Senate member TNMGR University and the national correspondent editor JOGI Journal and chairperson FOXY Adolescent Health Committee 2016-18. Madam is the retired director and a professor of IOG Madras Medical College and President Board of Studies TNMGR Medical University, member Board of Studies OG Meenakshi Medical College, and ICOG Governing Council member in 2015-20. So Madam has received various awards to her credit, like IMA Doctors Day Award by the IMA TN State Branch, Durusha Distinguished Community Service Award from FOXY, and Mr. N.A. Pandit and Shailaja Pandit Women's Empowerment Award from FOXY. And Madam has also written chapters in FOXY textbooks and FOXY Focus and newsletters. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am.
Thank you, Dr. Stalin. I welcome all of you on behalf of TNFOG. From TNFOG, we have been conducting this marathon CME on second Friday of every month. Last year, we conducted this more than 9 marathon CMEs. In that, we had the Yuva session where 2 Yuva competitors were present, and we had the winners of 1, 2, 3. They will be given awards in the annual conference when it is going to be conducted. From this year, we have removed this Yuva session, but the newsletter, all articles was written by only Yuvas from this year. So here hereafter the newsletters, the authors will be the Yuva in this year. Now I welcome our MOC, Dr. Meenakshi Sundaram, to conduct the meeting. Dr. Meenakshi.
Good evening, everybody. Thank you, Sampath, ma'am, and welcome you all for this wonderful TNFOG marathon. Always a focused meeting, and today we have a very interesting topic and wonderful speakers to add light to this. So we start the proceedings with the Tamil Thai Varthu. And to make everything bright for the evening, we have the lighting of the Kuttuvilakku to start the proceedings with the Thank you once again. Welcome to everyone. And I take great pleasure in inviting and asking Madam TNFOG President, Dr. Anjalakshi Madam, to take over this proceedings and give the welcome address. She is the founder president of TNFOG, past president of OXY, governing council member DIPSI, PhD in pregnancy diabetology from the Tamil Nadu MGI Medical University, recipient of the Best Doctor Award from IMA, retired professor from Madras Medical College, retired professor from Mother Medical College, presented numerous papers in national and international conferences, and her research area is on gestational diabetes. I did my first posting in OG with Madam, and always it's a pleasure to hear from her. Over to you, Madam.
Thank you, Meenakshi. Good evening, everyone. Respected Chief Guest, Dr. Suchitra Pandit, star speakers of the day, Dr. P.G. Pal, Dr. Muralidhar Pai, Dr. Jaydeep Tang, and Padma Shri Awardee Manjula Anagani, dear chairpersons and faculties, I am very much privileged to give the welcome address. Today, we are going to have the February month marathon CME on only tube. And all of us know about the importance of the tube. And we will be discussing on tubal pregnancy, which by Dr. Muralidhar Pai and Dr. P.T. Pal, an excellent flap surgeon who has trained many gynecologists, is going to talk on flap recanalization. And hydrosalpinx and infertility will be dealt by Padma Shri Dr. Manjula, and Dr. Jaydeep Tang, an excellent speaker, will talk to us on prophylactic salpingectomy in the prevention of ovarian cancer. For this program, to bless us, we have the great personality, Dr. Suchitra Pandit, who is close to us, and she has come to Chennai many times. We are really eagerly waiting for the physical meeting, Madam. Madam, I welcome you and request you to felicitate our CME. And to introduce Suchitra, Madam, CV, please. Madam is a consultant department OB-GYN Surya Group of Hospital, Mumbai, chairperson AICC RCOG 2017 to 2020, president ISOPOP 2018 to 20, president organization Discloses 16 to 21, president FOXY and ICOG 2014 to 15, FIGO Women's Awardee 2018, FOXY representative to AWOFOG 2015 to 17, President Mumbai Society of OB-GYN 2013 to 14, and Professor and Unit Chief LT MMC and LT MG Hospital Sion, PG teacher for more than 34 years. She has initiated the FOXY Dystosis Hypertensive Disorders in Pregnancy certificate course, and so far 105 courses have been done. Conceptualized FOXY Youth Mela for empowering youth, done more than 300, and she is continuing the activity still. And she is Secretary FOXY UNICEF Sion Kishori Adolescent Empowerment Project of the Dharavi for 8 years, winner of Lord of Planets Award UK 2019, FIGO Women's Award 2018, Maharashtra Medical Council Award 2018. So she has got innumerable awards and credits to herself, and she has awarded 35 orations and more than 2,000 guest lectures in India and abroad. With Madam, I wholeheartedly welcome you, and I also request you to release our newsletter of this month. I welcome the other speakers, chairpersons, and delegates for this wonderful program. I once again welcome everyone. Jai Hind. Thank you.
Should I start?
Yes, ma'am.
Yeah. Thank you. First of all, thank you very much, the entire TNFOG team, for this wonderful CME on, it's focused on tubes. And first of all, thank you, President Anjalakshi Chandrasekaran, and all the best to you for your elections. Congratulations to yourself, to the Secretary, Dr. Sampath Kumari. I know she's the absolute dynamo, because I have seen her working as a chairperson of the Adolescent Committee, and the number of programs she has done in my tenure, even as the FOXY president. And of course, the treasurer, Dr. Vijaya Lakshmi Dhanashekaran. I don't see her as of now, but I'm sure that, the three ladies have created this wonderful program. And of course, how can I forget the Vice President, Dr. Revati, Revati, I remember it gets us back to the days when I was vice president with Dr. Narendra Malhotra, and we had done the Bharat Jagriti Yatra. We did so many tree plantations in Madurai, and you taught me so many slogans in Tamil. So I still remember some of those slogans. So wonderful to see all of you. And of course, Dr. Chitra is also there, president of COGS. Attend a focus CME where you have stalwart speaking. You have a dynamic, dedicated teacher who's the dean of SMIMS, Dr. Muralidhar Pai, will be talking on the tubal pregnancy. And I think PG Paul is one of the, the pioneer laparoscopic surgeon of Kerala. And I remember PG Paul long time ago when he was vice president, and he's going to be talking of laps decanalization, always smiling and never a troubled expression on his face. And of course, to the second session, which is going to be by Padma Shri Manjula Anagani, who will be speaking on the hydrosalpinx and infertility, a very important problem that occurs time and again. And Dr. Jaideep Tank, who is a very, able Secretary General of FOXI, done remarkable work for FOXI for the last so many years, and now is all poised, to do his election for the President FOXI, and I'm sure he will be successful. Excellent orator skills and a very, very witty person. He'll be speaking on the prophylactic salpingectomy, and it's lovely to see the chairperson, my dear friend Ramani Devi, who is an expert on endometriosis and has been the past vice president of FOXI. So we kept seeing her time and again in so many programs last year. And along with her is another smiling face, president of Nagar Coil Society, Mary Ann Raja. And, best of luck to you also for your elections. And these focus CMEs always teach, the viewers and the listeners quite a bit, because you get to know the technical nuances of not only the pathophysiology, but also how to treat it. And you can ask many, many questions. And from my side, I would like to say that I'm contesting for the post of, the FOXI representative to FIGO. I got the FIGO award for
Not audible, ma'am.
Madam,
Madam, not
the network is narrow.
Not audible at all.
No, ma'am.
Everything was
I guess
audible.
the last few sentences, your network had some issue, ma'am. So
Okay.
we will.
Can I talk now?
Yes, you can. I think
would like
once.
to say that I've attended the last FIGO 7 conferences in, just spread over 22 years. And in 2018, I got the FIGO Women's Award for my work on women's health, and was very happy to receive it because it's a nomination by FOXI and it was approved by FIGO, and I received it at the hands of Dr. C.N. Purandri, who was a FIGO president then. I've attended the e-conferences also, and been a part of many of the workshops that are conducted by FIGO at on-site during the conferences also and also in India. So sincerely, I'm seeking for nomination at the present. The last date is 14th of February. And then the elections start. It will be with the presidential election. This will be in the third week of March. And sincerely, I am requesting all of you to please put in a tick mark against my name. And Nandri, for that, thank you very much. So please do remember me when you're doing the elections. And all the best for today's CME. All the best to TNFOG. Happy first birthday to TNFOG. And I'm sure there'll be great work done by this particular federation. Thank you very much for inviting me. And happy to see that wonderful face of the coordinator, Meenakshi. Thank you very much.
Thank you, madam. Thank you, madam, for that blessing.
Action newsletter.
Thank you, ma'am. It'll be a pleasure to release our newsletter for this month. So request Suchitra Pandit madam and our president Anjalakshi madam to release the newsletter for this month.
Wonderful. So this e-newsletter has now been inaugurated, opened rather. Wonderful. So this is fast work. It's already done and ready.
Ah.
Fantastic. Very nice. Sampath, I'll
Go to the
This,
class.
all the articles are written by you as speakers of 2021.
Very good.
be very happy to receive a e-copy of this.
Sure, madam. I'll send the link.
Very nicely done. And just in time.
All the best for your election, madam. Here, some
Thank you.
president
Thank
and
you.
secretaries are there. Ask, all of you nominate for that post.
Thank you so much. And Sampath, I'm very proud of the fact that you have received my, the award that I had instituted.
Yes, madam. I want to tell that award is from Dr. Suchitra Pandit only. That.
Yes. Madam, all the best, ma'am. Suchitra, madam, all the best.
Yeah.
Thank
Thank you, madam, and best wishes for your election.
Thank you, ma'am. Thank you, ma'am.
Best of luck, Dr. Suchitra.
Thank you so much.
Madam, all the best for your election. And I'm happy to say that I was also one of the
Yes.
proud recipients of your
Yes, of course.
award.
Yes, yes,
Shailaja
yes.
Pandit Award.
Shailaja
Ramani
Pandit
madam
Yes,
has
yes,
got.
yes. Yes, absolutely. Absolutely. Ramani, I remember that very much.
Thank you for the award also, madam. Yes.
Thank you, ma'am. Can we proceed to session 1 if we have our speakers here, ma'am?
Yes. PG Paul sir.
PG Paul is ready.
All right. Okay. Paul sir is there. I cannot see Dr.
Please
Murli,
ask.
but we can start with Paul sir, I think. So first, I would like to invite our chairpersons for this session. I think this session we have two interesting talks. One on the pregnancy in the tube and one on
Revati
how
madam,
to
PG Paul sir,
recanalize the
please
tube
do.
for the
Often.
pregnancy. So session 1, I would like to invite our chairpersons, Dr. Chitra and Dr. TV Chitra, Professor and Unit Chief of OBGYN at PSG Institute of Medical Sciences. She's
Make
the
it short,
president-
Meenakshi.
Sure, ma'am. President of COVI OBGYN Society and Scientific Committee member of UFOXC 2019 and member of IUGA and ISU OG. And her special interest is urogynecology and high-risk pregnancy. Welcome you, madam. And I also welcome our next chairperson, Dr. Revati Janakiraman, Vice President, Foxy South Zone 2016, former Director, IOG Chennai, and Founder Secretary of the Madurai Obs and Gynae Society, President, IMS Madurai Chapter. So welcome both of you, ma'am, to chair this session on the two interesting talks. And I would like you to introduce our speaker, Dr. PG Paul, today.
Thank you, Meenakshi.
Revati
Good
madam,
evening.
are ready and கேட்டுக்கோங்க madam.
I think he must be the Dr. PG Paul. Can you unmute? He's already logged in, ma'am.
Yes, Lord.
Yeah.
Yes, I am here. I am here.
Oh, welcome, welcome, welcome.
Hello, sir.
Good evening, everyone.
Good evening, sir.
It's my pleasure to welcome and invite Dr. PG Paul. In this ART era, IVF being the choice of many in managing tubal block, what best and how recanalization, that to lap recanalization, can help to achieve success. And that is going to be discussed by Dr. PG Paul, who is a stalwart in Gynae Lab. He is a chairman, Paul's Hospital, Kochi, and he is a board member of ISGE, elected member of the Society of Reproductive Surgeons, ASRM, since 1997. He has authored 2 books and contributed 35 chapters in books. He has published more than 40 papers in international journals. He was invited to give lectures in 383 societies and has done live surgery workshops in 242 places, given hands-off training to more than 1,800 doctors in Gynae Lab. He has received Lifetime Endoscopy Empowerment Award, IAG 2018, and also Distinguished Alumni Award from Trivandrum Medical College in 2019. The stage is yours, Dr. Paul.
Thank you, Dr. Revati. At the outset, I would like to thank the organizing team for giving me this opportunity, and I can see that all my friends, colleagues, and all we have met somewhere, any meetings. And the topic given to me is, can I share my screen?
Can we share Paul's screen?
He can do it.
Yeah, sir.
cannot share screen now.
We can't see it yet, sir.
No, I cannot.
Oh, you are not able to share it?
Chitrakala, can you help, sir?
Sure, ma'am. Sir, you can see the share screen in the, sir, first please open the PPT in your background.
That's already there.
Now please come to Zoom and please click share screen.
Am I logging through some other?
No, there's
No,
only
sir,
a
only
single
one.
Only one portal, sir.
Oh, only one.
So in bottom you can see the share screen. Green
That I
color
can.
one.
1 second.
Yes, sir,
Yeah.
you
Yeah,
started.
Yes.
Please minimize this window, sir. We can see your
Desktop.
Google Chrome. Yeah. Now you need to minimize this, sir.
Yes, sir, just go to your presentation.
Oh, okay.
Sir, can you please accept my request?
Oh, shield, some approve. You can
Yes,
get.
sir. Yes, sir.
That's why I was wondering why it's not.
No, can you approve now, sir?
Okay, okay.
Yes, thank you, sir. Sir, now you can open your presentation, sir.
Yes.
Is it okay now?
Yes, sir.
Yes,
Can you
yes.
please
Yes,
make it in
slideshow.
full screen?
Go to
Slideshow?
slideshow. Sir. Slideshow.
Yeah.
Yes, sir.
Yes,
Perfect, sir.
Oh,
Fine,
okay, okay.
perfect.
Thank you.
Yes.
Sorry for this confusion. I think this is an old debate because a lot of patients in India or across the globe still repent their sterilization, and it is approximately estimated that 4.5 million, 45 lakhs of women are annually sterilized in India, and around 2 to 13% of them regret the reversal, and this 1 to 3% really request tubal reanastomosis. And the most common reason for this request is either loss of children, or they want an additional child, or probably a remarriage. We already mentioned that now there is a competitive treatment available at the moment, and IVF is available in every cities and towns, and most of us are now familiar with this, and the technique of tubal reversal has become less popular and less surgeons are trained in this. So between these two options, you may choose what is more convenient to you. This is something like a Maslow's hammer. When you have a hammer, you think everything is nailed. Same thing, if you are well versed in IVF, you always suggest an IVF. Those who are trained in tubal anastomosis suggest whatever it is. In fertile women, both these procedures give equal success rate. Now I will be more discussing about the tubal anastomosis, and now just become a standard by performing tubal reanastomosis by laparoscopy. And we are all traditionally trained with the 2D laparoscopies, but with the advent of 3D and robotic, many surgeons are changing over to, because they have better control over the fine suturing with both this technique of 3D or robotic. I use 3D camera mostly for my tubal anastomosis, and the main advantage is you have a binocular vision. Something you have something like your two eyes. Lens has two actually objectives, which actually give you a stereoscopic vision. Many of our younger colleagues nowadays use the regular 5 mm Procar and instruments. I find it really clumsy, and tubal surgery should be performed with the finer instruments. I normally perform instruments of 3 millimeter. I will be showing what are common instruments I use. The basic instruments is, one is a grasper and second is a needle holder, both dedicated for 3 fine suturing, where you use 6-0 or smaller sutures. Main disadvantage of many readily available graspers are they are little traumatic on the suture, and when you actually tighten, the suture actually breaks if you are using 6-0 or smaller. So I suggest you should have a good quality grasper and needle holder with a traumatic grip, and you must be able to tie the knots without slippage. I normally tie it on hair and see whether it can hold on to a hair. That means there is a good grip without slippage. We use a chromoperturbator to check the patency of the distal stem. Scissors, I normally use the 5 mm scissors because 3 mm scissors are quite costly, and you have to repeatedly change the instruments. The standard suture I use is 6-0, although I have tried with the 7-0 proline or ethylone, but now I use 6-0 proline because it has a good color, which give you a good contrast with the tissues, and you should select a needle. Normally, the cardiovascular needle is the best because we can actually pierce the seromuscularis without actually holding on, without just counter pressure. So I suggest to use this cardiovascular CV needle for tubal anastomosis. And I will talk about the modifications I have recently started using is the barb suture. And the technique, all of us know that the knot should be outside the lumen. So outside in, inside out, and then make the knots. And this is the 2D laparoscopic suturing. We use vasopressin into the mesosalpinx to reduce the bleeding from the tube, because it's not a good idea to coagulate the bleeders because that can compromise the healing. So both layers should be prepared separately, the serosa and muscularis. This is the chromoperturbator, which you use it for the distal stem. The first suture is at 6 o'clock. Actually go through the mucosa because it's practically impossible to avoid the mucosa on the distal stem because the muscularis is very thin. And I use a contralateral knot tying, and it works very well, but definitely you can use ipsilateral, whatever technique you are used to. And the 6 o'clock suture is now cut short. Always continuously do chromoperturbation with very dilute one during the suturing because the distal stem get distended. So taking the suture is quite easy. So you take the 9 o'clock suture and 3 o'clock, and the 12 o'clock suture is done last. We finish the 6 o'clock first because that is the 12 o'clock suture. Here, actually, the lumens are reasonably good. It's quite straightforward to. I have selected a case where the lumen is reasonably good, but nowadays, most of our cases, we find if it is a fallopian ring, the lumen size will be less than 1 millimeter, which is really tough. We can see that I'm continuously doing the chromoperturbation so that the proximal stem get distended with the suture. Then few seromuscularis allows take away the tension at the suture line. You don't need many sutures. Normally 2 or 3 is good enough. You can see that the 3 millimeter instrument does not block your view. If you use a 5 millimeter instrument, you can see that scissors, what I used is a 5 millimeter, which actually blocks the view, and we are actually finishing the suturing process. This is, if you have not done the mesosalpinx, it's better to use the mesosalpinx first because when you otherwise move the tube, it takes away. And a chromoperturbation, there can be some leak at the anastomosis, but good dye spill give you a good confirmation that your approximation is reasonably well and you can expect a good result in such cases. I had published my results for quite some time. I've been using only one tube anastomosis. Ideally, we should do on both sides, but sometimes we may have only one good tube available, or because the pressure of the timing, I have been doing one, and we found that the results are almost same, maybe 5% less when you do only on one side. So ideally should be done on both sides. And majority conceived within 6 to 9 months. And if the patient doesn't conceive within 6 to 9 months, if the male factor is normal, you should look for alternative procedures. We started using barb suture in 2009, and since then we were trying to modify all our suturing with the barb suture, and the material is we know that is PDO, and the quilt suture was the one which was available in the beginning. Now there are many brands available, and the smallest suture available in quilt is 5-0. And basically it is designed for the plastic surgeon for approximation, and they have not really designed one which really suits tubal anastomosis, but I have tried, experimented with this suture to make it faster and easy for the beginners to learn. The technique is same. This is a 3D, that's why it's the picture is in the 4:3 orientation. You inject vasopressin on the mesosalpinx, you pull on the tube so that when you cut, actually the serosa retracts, and the mucosal opening and serosal opening, there is a space so that you can do this. These small bleeders, actually we don't coagulate because most of them stop spontaneously, and if you coagulate, it can actually extend into the mucosa, which is not a good idea. And you have to be careful when you make the incision on the distal stem, because many times it retracts into the serosa, as well as it makes a bigger opening, and this disparity between the proximal and distal end can cause difficulty in the suturing. So the mesosalpinx suture is taken with the regular 6-O-proline. Here you can find the needle is quite big enough and easy to take a bite. When you take this mesosalpinx, make sure when you tie this knot, the end should be in a reasonable approximation. You should not actually make overlapping, which can cause difficulty in the taking further sutures. So the first one is a regular suture, because you need a mesosalpinx suture before you start using the barb suture. Now this is kept aside, and what we have done is we don't use a single strand for the approximation. Instead, we cut this into two, and we take only 2 bites with one part, because otherwise when you try to tighten this, there will be a purse string effect, which is not ideal. So the first 6 o'clock, you take the serous muscularis and then go through the lumen. And actually I have made a knot at the end so that it will not slip. And same, the 6 o'clock suture from inside out is taken, and it's gently pulled on. The only problem with this suture is it is almost colorless, and the contrast is not as good as proline. Now you go to the 3 o'clock. The same suture is continued from outside in at 3 o'clock. Then I already mentioned that you continuously irrigate, chromopertubate at this point when you take the bite, so that the lumen will be distended. And that is one easy technique to identify the exact orientation. 3D comes very handy at this point, and probably robotic will be much easier. Meenakshi will be in a position to say how she find with the robotics. This is the second suture, which we started at 9 o'clock. Outside in, inside out. The serosa is not taken, the muscularis. And there is a knot at the other end of the suture, so that will not slip out. Because you need a little bit of traction so that you will not slip out, because the barbs are so small, it can easily come out. Now it is taken at 12 o'clock. The chromopatuation being done. That minimal bleeding we ignore, and I don't try to coagulate unless it's a big sputter in the mesosalpinx. Anything on the tube I will not. Actually, we have not really tightened, because if you tighten the first knot, first suture, then the lumen will become very closely approximated, so that the visibility will be compromised. Here I have just pulled out both, and after this layer you are checking for the tubal orientation and anastomosis. You can see the dies coming. The same suture which we have used at 3 o'clock, 6 o'clock and 9 o'clock is again continued on the right side. So the same suture which you use for 6 and 3 o'clock is continued to complete the seromuscularis. You may take 2 bites, and too much tightening should not be done, because the lumen can get compromised during this procedure. These needles are little clumsy ones, so it is little difficult to. Now you finish, take the other half of the suture we have taken. The 3 and 12 o'clock the bites we have already taken, and the same is continued onto the seromuscularis. Just an approximation is good enough, and the chromoperturbation is rechecked, and you can find good approximation. Currently, I have changed to the barb suture whenever the lumen is of reasonable size. Very small lumen, I still continue to use the 6-0 regular suture, and anastomosis is completed on both sides. And we had several pregnancies with this technique, so there should not be any problem whether the barb suture can compromise the pregnancy. And we did not have any ectopic pregnancy in this small series, but any tubal anastomosis can have an ectopic pregnancy. We had published this as a video article in CME, and the meta-analysis shows a pregnancy rate of almost 70%, 65 to 70%, and an ectopic pregnancy up to 7%. And if you look at the ART success rate, this is the old 2017 SART data, where the take-home baby rate is only 34%, and ectopic pregnancy is around less than 2%. If you look at the cost, definitely in India or abroad, it will be half that of ART. The most prognostic factors which affect is age of the woman, like ART, and you can find that the results are much better when tubal anastomosis in women older than 40. And very small tubes are not ideally suited for tubal anastomosis, or those with severe tubovarian adhesions. And the best results are isthmo-ischemic anastomosis. This is a lady, I think it's around 40 or 42, and she conceived of tubal anastomosis. This was on my old slide. The surgery was done immediately after the tsunami, where they lost their children. So to conclude, a small percentage of women will request reversal of sterilization, And ART is an alternative, but you know that it's more stressful and costly, and the chance of OHSs are all there. Tubal anastomosis gives a natural pregnancy in 60 to 70%, and it is less costly, and you can get more than one pregnancies. But ART has a definite role if the tubes are very short, there are significant adhesions or endometriosis, or there is a male factor. ART is the best option. Thank you all for the patient attention. And once again, I thank the Tamil Nadu Federation for giving me this opportunity.
Thank you very much, Dr. Paul. Excellent talk and excellent video presentation also. And suggestion of continuous chromoperturbation during surgery is really a good idea. And do you routinely advise pre-op assessment with the lab for all cases? Do you?
Pre-op, no. I just take a good history and look at the way she has been sterilized.
So that will be much better if you do a pre-op lab also, so that you can exactly assess the success and then whether to go for it or not.
No, it becomes double. I tell them if it is a good tube, that will become a procedure. Otherwise, it will become a diagnostic if the tube is bad. So one sitting. And we don't have time to do all diagnostics, and it's not good for the patient. So my diagnostic, most of the cases we try to perform the tubal anastomosis if there is reasonably good tube. I don't discard the case just because the tube is small or there are minimal additions.
Thank you. Thank you, sir.
Sir, do you use any irrigation fluid during surgery?
No. During my days of tubal open microsurgery with the microscope, we used to continuously irrigate with saline with the heparin. Here, we use the regular irrigation fluid because there is no real tissue drying.
Okay.
So in laparoscopy, I think probably we don't need that. It's already wet. We don't allow the tissues to dry up.
Okay. Okay. Thank you, sir.
So one thing, like how you were saying in robotic, I think it's wonderful because of the magnification and the finesse of the instruments and all. But like we discussed, the problem is if it turns out to be a diagnostic procedure, I mean, after going in, if you realize that you can't do anything to the tubes, it is too expensive to put a robo on that patient and see. So that is where sometimes with tubal recanalization, though the procedure is, there's a lot of advantage doing it robotically, I still get a little scared and I still prefer to do it laparoscopy for the reason that, after docking everything and then you look at it and then you'll have to
discard.
Yeah, I mean, abandon the procedure saying the tubes were not good, is too expensive for the patient.
I think how easy you find it? I think it should be comparatively straightforward, easier than doing.
Yeah, because one quadrant surgery, just 2 tubes in view. And the needle holders are very fine. Suture material is very fine. So the anastomosis and all, because hardly any bleeding in that area. And your assistant can keep that continuous irrigation in that if you want, if there is a spot bleeder also. So that
the graspers are bigger for the 6-0 needle.
Yes, but we have the large needle holders and the mega needle holders. The large needle holders have little finer tips. So those are good for holding the suture.
So there is one question in the chat box. If you use tubal wire, will it be easy to anastomose? To keep it in situ?
No. During our early days, we used to use Prolene from the tubal end, also hysteroscopically. But if you can clear the magnification allow you to see clearly. So there is no real advantage in doing a stent inside. That's what I have found. But as a beginner, probably you can try. But I don't think you must learn without a stent because you should use the magnification to clearly see. And if you want to stain, you can use the methylene blue to see the mucosa very clearly.
Thank you. Thank you, sir.
Do you think this anastomosis has to be really watertight without a leak? Because many a times you find that there is some amount of peritubal, around the anastomotic site, some fluid getting trapped.
it can come, but if the dye doesn't come from the other end.
No, the dye does come from the other end, but there can be a little
no problem. It need
symptomatic
not be. It need not be water dye. Need not.
All right. Okay.
Thank you, sir.
Okay.
Move on to the next session.
Thank you.
Dr.
Thank you.
Sampath Kumari, I'm back. Can I talk
Yes,
now?
Yes,
Yeah.
yes. It's your turn. Chitra madam, introduce her.
Okay.
May I request?
Welcome, Dr. Muralidhar.
Yeah, thank you. Sorry for the late joining.
No problem, sir. We manage with PG Paul, sir. I agreed to talk in the first.
Yeah.
Okay, a very good evening to everybody present. And it's indeed my proud privilege to introduce Dr. Muralidhar Pai. He's a Dean of Sikkim Manipal Institute of Medical Sciences. He's a professor of obstetrics and gynecology. In fact, I've had a long association with Dr. Muralidhar Pai for almost, I think, 10, 15 years. And for every EMOC of our PG refresher course, he's there. And I see him so frequently, almost every other day, there's some PG program, everything on the YouTube. So I'm thinking of becoming very, very famous. I do not know whether they want to become the next president of Foxy.
No, not at all. Because now this I have clarified to everybody.
Yeah.
I don't aspire to be president, vice president, secretary, treasurer, member of any committee of anything. I just want to keep teaching, and I wish that I keep doing that till my end. That's the only thing.
I can see you're a very, very passionate teacher. In fact, all his talks, he makes it so simple and so nice. It's really a pleasure to be listening to him. And welcome to this topic, Dr. Muralidhar Pai. In fact, pregnancy is a very welcome event which occurs in every family, but sometimes it really doesn't happen. Everybody is happy. They're looking forward to having a nice, healthy baby. But once you confirm a pregnancy and say the pregnancy is something is wrong, it is not inside the uterus, the pregnancy is in some other place, it really creates a havoc amongst everybody. So everybody's wondering, what will I do? Will the tubes go off, or can I preserve the tube? So for that discussion, we have Dr. Muralidhar Pai, who will be really enlightened with us about this. Welcome, sir, and please go ahead.
Thank you very much. I'll just share my talk straight away.
He's hero of PGs and good singer.
Yeah.
Okay. So, okay, all right. Yeah. I will straight away get into management because I don't want to waste the time talking about other things. First of all, the diagnostic evaluation, once you suspect ectopic pregnancy. In earlier part of my talk on the diagnosis part, I always tell that there should be high index of suspicion. And if I have to quote my professor, teacher, mentor, Dr. Pratap Kumar, he used to always describe ectopic pregnancy as a dark cat in the pitch darkness. So you have to have high index of suspicion. So first thing will be obviously to confirm pregnancy that, yes, she is pregnant somewhere, right? Evaluate the patient for hemodynamic instability. So always I tell that whenever a patient comes to you, whether it is pregnancy or otherwise, in the first few minutes, 1 or 2 minutes, you must realize or you must ascertain that whether the patient is going to deteriorate in another next half an hour or so. So hemodynamic instability assessment is a very, very important step, especially in the management of ectopic pregnancy. Then comes, you have confirmed pregnancy, but you are not very sure whether it is inside the uterus or not. You will do a transvaginal sonography, which is better than the abdominal sonography. Yet you don't find a sac inside the uterus nor outside the uterus. That will be called PUL, that means pregnancy of unknown location. But remember, 40% of PUL will be ectopic pregnancy. So you cannot neglect PUL. And I'm going to talk exactly how to deal with the PUL subsequently. Serial TVS and HCG are a must, especially when it is PUL. I will talk more about HCG doubling time, etc. in the subsequent slides. Serum progesterone was also thought of, but there is a lot of controversy. I'm going to deal with that in the subsequent slides again. The problem with progesterone estimation is that definition of low progesterone is unclear. Of course, these are the general investigations like CBC, blood group and type, because all these patients would have lost a lot of blood. They require blood transfusion. Also, some patients would have slipped into DIC. That's why coagulation profile is also a must. And finally, if you are thinking of conservative management giving methotrexate, you need to have a pre-treatment LFT also. Now, I will deal one by one. Patient is hemodynamically stable. What are we supposed to do? Step one, of course, is history. But we must remember that 50% may not have a risk factor at all. Even though she is the first time pregnant without any previous pelvic pathology, she can still have an ectopic pregnancy. That should always be kept in mind. Physical examination, again, a gentle PV should be done, else the ectopic may burst because of your manipulation itself. And the famous finding is cervical motion tenderness. Step two is HCG. And not only one-time estimation, it also has to be serial beta HCG every 48 hours. Transvaginal sonography is the diagnostic modality to differentiate between three problems of first trimester, namely ectopic pregnancy, intrauterine pregnancy with an abortion, which could be threatened or inevitable, incomplete, or whatever it is. And the third problem is the vesicular mole. So all the three things can be clarified in one sitting, that is TVS. But we must remember the sensitivity of TVS is only 10.9%. We sometimes overdiagnose ectopic, sometimes underdiagnose ectopic. But whenever you diagnose, the specificity is 95.2%, especially when the HCG levels are more than 2000 milli-international units per ml. I will exactly tell you what are the TVS findings to make this kind of a confirmatory diagnosis. Yes, here it is. Ectopic is suspected in a pregnant patient with no evidence of an intrauterine pregnancy on TVS and any of the following. Visualization of a complex inhomogeneous extra-ovarian adnexal mass, 89% of the cases you will find this. An extra-ovarian adnexal mass containing an empty gestational sac, tubal ring, which is slightly better than simply seeing an adnexal mass. That could, for all you know, it could be a case of corpus luteum. So if you see a gestational sac, the diagnosis becomes much better. Finally, you can also see an intraperitoneal bleeding on TVS. Maybe it has gone for a slow rupture, or whether it has gone for a tubal abortion or even a proper rupture of tubes. And then you go by the HCG, serial HCG that we have been doing. Earlier, we used to say that there has to be a rise of 66% to say that it is going towards intrauterine pregnancy, or there has to be a decline of 15% to say that it is failing wherever it is. But now there are different levels we see in different literature. I'm going to tell everything and we can take a decision based on that. If the abnormal rise is less than 35%, we need not wait for 66% as per the old teaching, then the strong suspicion of ectopic will be there. However, the NICE guidelines are still maintaining 63% rise. Anyway, I'm going to clarify that further. Expected rise is dependent on actually initial HCG level. So it is neither 35 nor 63 or nor 66. It actually depends upon what was the initial value. If the initial value was less than 1500, then you expect a rise of 49% because it is still growing. But if the initial HCG was between 1500 and 3000, most of it has already probably come. So you would expect only a 40% rise after 48 hours. But if it has already reached more than 3000 milli-international units per ml, you may not expect a rise more than 33%. Probably that is the one which is the basis for saying a rise less than 35% is in the range of ectopic pregnancy. So how do you confirm further? Visualization of an extrauterine gestational sac with a yolk sac or embryo with or without heartbeat is much better than simply seeing an adnexal mass or a gestational sac. Yolk sac and embryo makes the diagnosis more confirmatory. And if you see a heartbeat, nothing like that. A positive HCG and no products of conception on uterine aspiration. Now, uterine aspiration is controversial. I'm going to again clarify that point, with subsequent rise or plateauing HCG levels. That means you have already done an aspiration, so there is no chance that the rising HCG is due to intrauterine pregnancy. It has to be ectopic pregnancy. Visualization at surgery. Again, I want to tell you, we don't do surgery, whether laparotomy or laparoscopy, just to diagnose ectopic pregnancy. But if you have clinically diagnosed ectopic pregnancy, if there was a strong suspicion of ectopic pregnancy and you decided to do a laparoscopy, then you will see the mass and obviously you will resect the mass and send it for histopathology. And if the pathologist says it wasn't definitely an ectopic pregnancy, that is nothing like that. We all know the final diagnosis is always with the pathologist, but that is not the best way of diagnosing ectopic pregnancy. Discrimination zone. I want to talk about this also because different books give different things and postgraduates and everybody gets confused. 1,500 milli-international units, the gestational sac is visible inside the uterus only in 80% of the cases. When it is 2,000, 91% of the cases. That's exactly in the slides couple of before this, you saw 2,000 as the value. When the value is 3,510, 99% of the cases should have intrauterine pregnancy sac. So one may say the real discriminatory zone is 3,510. But the problem with that is it is too late. Setting discriminatory zone at 3,510 increases the ability to diagnose a live intrauterine pregnancy on TVS, all right. But it also increases the risk of delaying a diagnosis of an ectopic pregnancy. And if you are unlucky, if the patient is unlucky, it may rupture as well. So discriminatory zone A has to be very carefully determined based on what you can see above. But TAS, the value is 6,500. It is too late and nobody does TAS to diagnose ectopic pregnancy. Progesterone levels. I promised you to talk about progesterone levels. For bleeding or pain abdomen and an inconclusive TVS, anything less than 3.2 had a sensitivity of 75% and a specificity of 98%. But for the patients with bleeding and pain alone without a TVS, progesterone values less than 10 nanograms enough to say that it is probably an ectopic pregnancy. Having said that, you must be very, very careful in interpreting that, because the low serum progesterone concentration for predicting a non-viable pregnancy in spontaneously pregnant patients are different from those who have undergone controlled ovarian hyperstimulation for IVF or IUI. Obviously, because in a spontaneous pregnancy, there is only one corpus luteum. So obviously the value of progesterone will be different compared to an IVF or an IUI where the number of corpus lutea would produce the progesterones. That this has to be kept in mind. I told you I will clarify the uterine aspiration controversy. Curettage or aspiration as a diagnostic tool is limited by potential for disruption of viable pregnancy. Yes, what if it was a normal pregnancy which was not seen by TVS because you did TVS very, very early? So it is wrong to go and do an aspiration to prove that there is nothing in the uterus, that's why it is ectopic pregnancy. But the other thing that you can think is only on patients with both an HCG concentration below the discriminatory zone and a low doubling rate, probably this is justified. Approximately 30% of these patients have a non-viable IUP and the remainder will have ectopic. So there also, you are not 100%, only 30% will have IUP. So the sensitivity of curettage in finding chorionic villi is only 70%, PIPL is 60%. That is another problem. Many believe it is more practical and less invasive to continue observation or administer one dose of methotrexate. Meaning some people think that methotrexate is more dangerous than uterine aspiration. Well, it can be argued any which way. The side effects of one dose methotrexate is negligible is one argument. Another argument is that aspiration carries a risk of intrauterine adhesion formation or sometimes perforation or sometimes disruption of a normal pregnancy. So whatever you do, you have to be very clear and justified in doing whatever you do. There was no significant benefit of one approach over the other as far as this particular study. Culdocentesis. This was an old method of diagnosing ectopic pregnancy. Historically, it was used when the blood was detected, but this finding can be easily demonstrated with TVS nowadays. In fact, blood in cul-de-sac may also be the result of a ruptured ovarian cyst. Hence, culdocentesis positive for blood is non-diagnostic and not used anymore. It's out. So now I come to the follow-up, the step 3. If it is a pregnancy of unknown location, how to do? You have to do obviously serial beta HCG every 48 hours to 72 hours. Better is 48 hours. A rise in HCG more than 35% happens in normal early intrauterine pregnancy every 2 days. 99% of the cases showed this with a sensitivity of 92% and specificity of 94%. Whereas plateauing or decreasing by 15% most consistent with failed pregnancy. So anything suboptimal rise or a suboptimal decrease is in the range of ectopic. I hope I'm very clear in this slide. So what is the natural history of ectopic pregnancy? Usually they can have a tubal abortion, that is expulsion through fimbria, and followed by a resorption of the tissue or reimplantation of a trophoblast in the abdominal cavity, giving rise to secondary abdominal pregnancy or a ovarian pregnancy. Occasionally may need surgical intervention also. But most of the patients go for tubal rupture, which is a major cause of maternal mortality in first trimester. Very, very, very rarely they can regress also, but it is highly unpredictable. A word about ovarian ectopic. 1 in 2,100 to 1 in 60,000 accounts for 1 to 3% of ectopic pregnancies. Diagnosis is typically made at the time of surgery only because very difficult by TVS. All you see is some adnexal mass. You are not very sure whether it is tubal or ovarian. Strict histopathology criteria should be used. The exact diagnosis is not clinically important, but surgery is needed, whether it is ovarian or ectopic in the tube. Methotrexate has been used, but not been very successful. There are only case reports. This is the famous Wilbur criteria. The fallopian tube on the ipsilateral side must be intact. The fetal sac must be intra-ovarian. The ovary must be connected to the uterus by ovarian ligament. And finally, ovarian tissue must be located in the sac wall when the pathologist sees that. How to manage an interstitial ectopic? It's also called cornwall pregnancy. It accounts for again 1 to 3% like an ovarian. It is difficult to distinguish from eccentrically positioned IUP sometimes, especially if it is a post-IVF pregnancy. Usually, it presents very late, around 8 to 10 weeks, with rupture occurring approximately in 20 to 50% of cases less than 12 weeks. So you can expect a delay of 4 days in the diagnosis of an interstitial pregnancy. The screening of an asymptomatic patient is not usually done because it is not worth it unless it is an IVF pregnancy or a pregnancy happened after reconstructive surgery, or if there was a prior history of ectopic pregnancy. The same clinical protocol may be used, that is, keep on doing every 48 hours, go by rise of more than 35% or decline of 15%. If it is in between, that is ectopic. So if the patient is not desirous of pregnancy, she doesn't want, even if it is intrauterine pregnancy, how to do? So you have to do an active management. What do you mean by that? You can do a diagnostic uterine aspiration with laparoscopy if an adnexal mass is found, and or methotrexate. That means there is no point in simply waiting and simply keep on repeating the beta HCG. Straight away go for an aspiration. If it is intrauterine pregnancy, you have taken care of it. And if it is an ectopic pregnancy, which is within the limits of methotrexate, give that. But if it is outside the limit of that, go ahead with the laparoscopy. That's the meaning of this. It may reduce the number of follow-up. So COVID-19 has increased the ectopics because there has been a delay in diagnosis, reduced access to routine prenatal visits, and patient reluctance to obtain medical care early. So how to choose a treatment? The three approaches in the management of ectopic pregnancy, number one is surgery, which includes salpingostomy or salpingectomy, methotrexate, and finally expectant management. What is the Cochrane review as far as methotrexate versus surgery? Treatment with methotrexate has comparable efficacy to surgery and results in similar fertility outcome. That means you don't have to do surgery for every single patient of ectopic pregnancy. So, which are the patients who select for methotrexate? When the patient is hemodynamically stable, this is very important. If she is not, then you have to do a laparotomy or laparoscopy, whichever you are skilled with. HCG concentration should be less than 5,000. No fetal cardiac activity detected on TVS. Ectopic mass is less than 3 centimeters, preferably. And patients should be willing and able to comply with post-treatment follow-up and have access to emergency medical service. All the three are important. She should be willing, able to comply with the post-treatment follow-up, and she should have an access. Otherwise, you have no business to give methotrexate. It is contraindicated actually in cases where patient is dynamically unstable, and there is a heterotropy pregnancy that is coexisting intrauterine pregnancy because you will be killing both. Signs and symptoms of impending or ongoing rupture, surgery is better. Clinically important abnormalities in baseline hematologic, renal, or hepatic laboratory values because methotrexate is contraindicated in those patients. Immunodeficiency, active pulmonary or peptic ulcer disease. Hypersensitivity to methotrexate and breastfeeding. What is the therapy consists of? Single dose of 50 milligrams per meter square or 1 milligram per kg, or multiple dose, especially if there is a interstitial pregnancy or a cervical pregnancy. Factors that impact efficacy are the original or the initial beta HCG. If it is very high, obviously you require multiple dose. Fetal cardiac activity, actual contraindication for methotrexate. Large size, again contraindication. Peritoneal fluid, better to do surgery. And others like seeing yolk sac is to make high folic acid because that's an antagonist to the methotrexate. The follow-up, you repeat beta HCG after 7 days. If it is more than 15% decline, that means you are happy. And then you keep on repeating it until the levels are undetectable. Usually it takes around 35 days. But if the decline is not 15%, between 7 and 14 days, you may have to give additional methotrexate. And if 3 weekly values are similar, then you can repeat methotrexate, but a maximum dose of 3. If HCG is rising, TVS should be performed, and you must see that the pregnancy is growing maybe, and you have to tackle differently. If HCG does not decline to 0, always keep in mind that a new pregnancy is a possibility. While a patient is on methotrexate, avoid vaginal intercourse and new conception because both can be dangerous. Pelvic examination also should be avoided. Sun exposure because it will cause dermatitis, and vitamin containing folic acid should be avoided. That will negate the effect of methotrexate. And finally, non-steroidal anti-inflammatory also should be avoided. What are the outcomes? It is less successful than laparoscopic salpingectomy when you give single dose. However, when additional doses were given, if a single dose was successful, there was comparable efficacy. So don't get disheartened when one dose has not worked well. There was no significant difference between systemic methotrexate in a fixed multiple dose regime and surgery. So that is the meaning of that. So other outcomes, of course, in spite of giving methotrexate, there can be a tubal rupture. That's why a very strict follow-up is required. But though it is less, that is 31.9 per 100,000, it is a positive. Ovarian reserve, of course, does not appear to compromise. Fertility rates are similar, and there is a patient with ectopic first pregnancy has increased risk of preterm birth, low birth weight, and placental abruption. Subsequent ectopic, it is same whether you did surgery or gave methotrexate. Finally, I come to the surgical management. Salpingectomy is now preferred because salpingostomy has a small risk of retained trophoblastic tissue and an increased risk of recurrent ectopic pregnancy. Both salpingectomy and salpingostomy can be done either laparoscopically or by laparotomy, depending upon the surgeon's skill. Both procedures appear to have similar subsequent fertility rates, so anything is okay. Expected management, there is a small portion of patients with ectopic pregnancy deserve this, and a very low risk of tubal rupture patients only can be considered for this. Other conditions, TVS does not show an extrauterine gestational sac nor demonstrates an extrauterine mass suspicious of an ectopic pregnancy. HCG is less than 200. And again, the same sentence comes again, that is, patient is willing, able to attend post-treatment follow-up, and have access to emergency medical service. So there are interstitial and other ectopics. You have to give multiple dose. I have already told this. Success rates are somewhere between 66 to 100%. May require surgical management later. Mifepristone has been tried, but we don't use it because it may be, if at all, can be used in methotrexate, but we have not seen good success with it. The latest drug is gefitinib, but again, there was not a good success rate with this. That's why further studies needed before gefitinib can be used to treat ectopic pregnancy. Thank you very much for the time and patient listening. And again, once again, sorry for the late login.
Fantastic, sir.
Thank you, Dr. Murli. That was indeed a very excellent presentation. You gave an overview about the entire thing about ectopic. Now, I just wanted a small clarification. When you said about methotrexate, you said you repeat the beta HCG after 7 days. Should we not do it after 4 days and then repeat it after 7 days?
Yes, yeah, I do agree. I purposely skipped that. See, earlier practice was, we used to do even Manipal, even till recently we used to do, one is after 4 days and other one is after 7 days. See, after 4 days, if it is raised, then it is said that you repeat after 7 days. Don't do any action at that time. Then why it is waste? That's why I didn't go for 4 days. So, but even after 7 days, if it is raised, then definitely it calls for a second methotrexate. So why waste one beta HCG in between on 4th day? That's why I didn't mention that. And
Dr.
also we have
Shall
seen.
I add one more point? See,
Please,
most often when we do it repeat it on the 4th day, there is a hike of the beta HCG.
Exactly. That's what I was about to tell you. Interrupted me.
Okay. Sorry for
No. It's okay.
So,
it's the same thing. I agree with you.
Also,
you know what happens when even this happens even in molar pregnancy.
Yes.
It happens even in molar pregnancy. When you give methotrexate, that's exactly why when I was in Charing Cross Hospital, London, they used to admit the patient straight away for 3 weeks. I asked this question to Professor Bagshaw and Newlands. Why do you straight away admit for 3 weeks? They said, after the first dose, that is the weekly regime, what we give, 1 day methotrexate, 1 day folic acid, they expect high bleeding and high HCG in the 2nd week. And patient gets disturbed with that. That is the time actually everything is crumpling and dispersing into the bloodstream. So when after the 2nd course, it will come down. So they discharge the patient after 3 weeks. So same thing may happen in ectopic pregnancy also. Methotrexate is acting and beta HCG may actually increase on 4th day. Wrongly so. I mean, wrongly so.
No, it happens because we've also seen 4th day, we tell them. And then 4th day, very often it increases.
Yeah.
So the patient will be in a fix whether to go ahead with surgery or to.
We are also fixed more than that.
Yeah.
More than the patient, we are in a fix.
Yeah, what to do.
One more thing is, in patients where the ectopic sac is more towards the fimbria, we would have noticed after 1 or 2 doses of methotrexate, the patient goes in for fimbrial abortion.
Yes.
They will present with hemoperitoneum, and those people might need an emergency laparoscopy.
Yes,
so I generally advise these women with the initial high level of beta HCG, say levels beyond 5,000, or in situations where we need to use methotrexate with the fetal heart, I get them admitted.
Yeah, and not only that, this methotrexate, to be frank, you have to have a lot of patience more than the patient. Patient should have patience anyway.
Yeah,
But
correct.
you should also have patience, because I have seen these patients lurking beta HCG for nearly not 35 days, even 45 days, 60 days, and they keep on pestering you, doctor, please do a laparoscopy and finish it off.
No
Yeah.
need.
Meenakshi looking happy because her hands must be itching. Isn't it, Meenakshi? So why don't you straight away send it to me? I do a robotic surgery or laparoscopy.
True. Sometimes, patients are also like cat on the wall. They are also anxious.
Yeah.
We're also anxious most of the time. So
yeah, there is one more situation in obstetrics where IUD happens and patients want immediate expulsion of IUD. How much ever we explain to them, wait for 7 days, wait for 2 weeks, nothing will happen. They will not listen to us.
Okay.
Sorry.
Okay. So if there are no further questions, I thank Dr. Muralidhar Pai for the very interesting discussion and for the very interesting interactive session. Can we move on to the next session? And I think Dr. PG Paul and Dr. Muralidhar Pai did a very excellent presentation, both on the tubes. On one side, I think we're here to hear about the next controversial topic, salpingectomy, following the reconversation. What is there in store? Thank you so much, both of you all. And
thank you, chairpersons, for
ma'am
this.
and Anjalakshmi ma'am for this opportunity.
Thank you, ma'am, and thank you, chairpersons, for this wonderful session. And thank both our esteemed speakers. We move on to the next session. I'd like to hand over the session to Dr. Vanitha.
Thank you, Meena. After that very informative session 1, we now move on to session 2, where we would have talks on opportunistic salpingectomy and hydrosalpinx by eminent speakers. May I now take pleasure in inviting the chairpersons, Ramani Devi Madam. Ramani Devi Madam is a very, very renowned and popular face among gynecologists. Her CV, as you can see, does not fit into a single slide on any way. Madam,
Anita, you can just stop it. Stop it. Stop it. Just introduce
I
me.
take pleasure in inviting you to chair the session, ma'am. And
Thank
we
you,
have Dr.
Anita.
Mary Annie to co-chair the session along with Madam. Madam is a consultant obstetrician and gynecologist. She's the president of the Nagarcoil Obstetric and Gynec Society and has several awards to her credit. I invite both Ramani Madam and Mary Annie Madam to take over the session.
Okay.
Anita,
yes, ma'am. We have Dr. Manjula Anagani Madam CV coming up next, ma'am.
Is Manjula Anangani there? Yeah,
Yes,
I can
hi,
see that.
Ramji,
Hi,
ma'am.
Manjula. It's really a pleasure to introduce Dr. Manjula Anangani, who is a Padma awardee in 2000.
Madam, Dr. Ramani, you should also stop at introducing.
No, see, I am familiar with all this TNFOG group, but you should be made familiar. See, I should tell at least something about your achievements and your Padma Award for the distinguished service in the field of medicine by President of India. And she is a Guinness record holder for removing the highest number of fibroids in a single patient, 84. See the number. She has been a clinical director, head of the department, OBGYN Care Hospitals, Hyderabad, visiting laparoscopic surgery in overseas, Dubai, and I think in some of the African countries. But again, an honorary associate professor in NTR University. She has got a rich experience of more than 25 years of clinical and academic excellence, and awarded the Surgeon of Excellence by SRC USA in association with NMC Dubai, and awarded the Legend in Field of Gynecology by Times of Healthcare Achievers, awarded Hall of Fame in Obstetric Gynecology by Times Healthcare Excellence in Telangana, many healthcare excellence awards by Foxy, Best Presentation, and CS Don Awards, etc. Area of interest is minimally invasive surgery, high-risk obstetrics, especially for her innovative techniques, and many publications in Foxy Focus and many journals. And she's a good friend of mine. I am very happy to chair the session for Dr. Manjula. Go ahead, Manjula. And it is quite an interesting topic also. Hydrosalpinx in infertility is a very, very interesting topic.
Right. When Vanitha asked me whether I will talk, I tried getting away from it and I said, Vanitha, can you ask somebody else? Because I was still in Dubai and then I had to come back and then make it. She said, no, madam, please, and all. So, and then unfortunately, I'm actually presenting from bed. I had a fracture of the leg and I'm still I had time to prepare the slides in the last 2 days. So even if you have some mistakes in the slides, please bear with me. And then I thought, let us start with all of us are gynecologists. We all know we have been dealing with hydrosalpinx. So what do we know about hydrosalpinx? We know that it's a heterogeneous entity. It is a spectrum of pathology and distal tubal occlusion of any cause. It can be with potentially different outcomes. So anything can cause it, anything can obstruct it, and outcomes also unpredictable. So any distal tubal occlusion can lead to hydrosalpinx regardless of the cause, but the main cause is PID. Still, as of today, we always talk it as rather than adhesions, rather than anything iatrogenic, it is a PID, and chlamydia is still the leading cause for the tubal damage, hydrosalpinges, ectopic, and infertility. So impact, that is what we look at with hydrosalpinges. When in the whole thing, when Vanita told me, madam, we will talking about more of infertility, then I said chronic pelvic pain also is a very important reason why they have infertility. Just because the presence of that, even though is not being the ambulatory effect for the sperm or the ova, it is a negative impact of hydrosalpinx on IVF. Outcome is the most important thing. Apart from the heterogeneous entity and have become the different effects, the chronic pain and the dyspareunia which comes with it also can be the reason for the infertility. So here we know when ultrasound shows, it is very easy for us. One good pelvic ultrasound by a good sonologist, yes, there is hydrosalpinx. But we also know that sometimes they tell hydrosalpinx is there. Next time they go to another sonologist, they say everything is normal, and we are worried. When is the secretion there? Is it around ovulatory time, or again disappears before periods or during periods or not? Then the other things come like HSG, where anatomically there is HSG, but physiologically, when you're doing a hysteroscopy or laparoscopy, we again do not say it. Then you have a sonosalpingogram when it is there. So how do we detect? Suggestive history of infertility, PID, endometriosis, pelvic surgery, anything, we know that yes, chance is there. Suggestive investigations are a good ultrasound, HSG, sonohysteroscopy. So investigation before surgery or whatever treatment we want to give, if at all we want to give, will it work? Any medical management works? We all know it doesn't work. Always the damage is gone. It is like, I tell my patients, everybody wants the water to go from A point to B point. Means you have a water tank, you have a connection from the water tank to your house. You want from A point to B point the water to go, that is fine. Whereas in the human being, this is not just a pipe to take a water from one point to other point. We want this pipe to take the sperm towards the egg in one direction pre-ovulatory and the egg into other direction around ovulatory, and this whole baby back into uterus in the opposite direction after the ovulation. Means we are wanting the tube to function in a different way. So once there is a damage of the mucosa and the whole hydrosalpinx happened, as good as it is not going to function for fertility in any purpose. It is as good as a lead pipe where it is only going to be positive. The tubal press patency test may be positive, but functionally it is not good. So we need a surgery, but what type of a surgery are we looking at? Are we looking at delinking? Are we looking at only the aspiration? Are we looking at salpingectomy? So what investigations we do before surgery? It is a laparoscopy and salpingoscopy at the most we want to do. So HSG sensitivity is 63% and specificity is 80%, but I always say it is the eyes, the man behind the machine, which is important, what we see, which is important. So laparoscopy and chromoperturbation is the gold standard when we say that. And again, it is the surgeon's eye, because what I find is as hydrosalpinx in a smaller case might not be looking at it, but that's where actually the hysteroscopy is very important. When we do a hysteroscopy and when we see a wide open ostia, we know the functioning tube on the other side of it is not a good one. That is chronic endometritis with the hydrosalpinx on the other side. So it is not just a laparoscopy, it is a hysteroscopy which will actually give us whether the tube is hydrosalpinx or not. So TVS is a better evaluation. Sonohysteroscopy will have sensitivity of 90% and specificity of 70%. So if it is like this, all of us, we are very clear. We know it is hydrosalpinx, even though medially it is good, it is a lead pipe-like, so it is a tuberculosis which has caused this. So this HSG is very easy for us to know. Sonohysteroscope, if something like a scan showing like where there's a dilatation of tube like this, again, it is very clear. So anything which is clear, we are not worried about. It is where the recurrent IVF failures, where the implantation failures, the outcomes are bad, and that's when we are looking at. When the ultrasound, what waist sign is there, incomplete septae will be present, which is leading to this falling out, and thickened longitudinal folds, which is called the cogwheel appearance, is what it is there. Now, all these something which we need our best friend in ultrasonologist, which is going to tell us, and that is where we are looking at. But then the gold standard for us laparoscopic surgeon is always the hysteroscopy laparoscopy. He who climbs the mountain will always get the best view, and he or she who puts the scope will always get the best view. So we put in a scope in the hysteroscope to see the ostia and into the abdomen to see how the tube is doing. That's when we take a call about what we want to do. When it is distal lesions, if it's only fibrosis and only fibroplasty you do, and then the tube can, if it's not completely gone, the lining is fine, we can just save the tube. But if it is a hydrosalpinx, that is because of complete obstruction, definitely it either needs neosalpingostomy or salpingectomy or proximal occlusion. So proximal lesions, if it's a functional or organic, we do a hysteroscopic surgery and you do a pregnancy rate, take-home pregnancy rate can come up to a 48% with FTC. Mid-segment, then it is blocks or ectopic pregnancy or reversals, we can always look at. All these hydrosalpinges can lead to it. But tubal surgery does not rival the IVF, but it is complementary. In today's time, most of the time when it is tubal factor, I always tell the patient, why do you want to do anything? Just go for IVF because that is a better outcome. But saying that, if hydrosalpinx is patent and the infection is going to come and then affect the baby in sitting it, then it is salpingectomy where the outcomes are going to be good. So how does it affect the fertility? Fertility treatment info says that constituents of hydrosalpinx fluid will inhibit the epidermal growth factor, tumor necrosis factor, cytokines, integrin B, and growth factors. All this rigmarole, all these fodder are all well known by all the IVF specialists rather than us, because these are very, very small, intricate things that are very important in the growth of the baby and the pregnancy. There are so many theories postulated. It can be the mechanical effects, which is effect on embryo gametotoxicity, alterations in the endometrial receptivities, direct effect on the endometrium. So whatever it is, when you know it is not going to be good, conducive for the baby to grow, and it can actually be very bad for the baby, it's very easy for us to convince the patient. So many times patient comes to us and said, when we do a laparoscopy and the scan tells us, it tells them very, very clearly that we do not want to remove the tube, but when I do a laparoscopy and when I see the hydrosalpinx, what do you want us to do? Do you want us to remove the tube or not? Many a time patients will tell us, we don't want the tube to be removed. But when we give the right picture saying that hydrosalpinx can go and cause a problem, then the patient then definitely remove. Dr. Mary, you're not muted. So the outcomes are, it impairs the ovarian function, follicular development and oocyte quality, and endometrial damage, purely dilution of the hydrosalpinx fluid and essential nutrients and substituents, direct cytotoxic effect on gametes and embryo, inflammatory response and production of pro-inflammatory cytokines, mechanical washout of the embryo, which is going to sit there because of the liquid coming out, and effect of the endometrial receptivity and inhibition of embryo implantation. So studies have shown that diminished potential of endometrium for transplantation is transient, and pre-IVF surgical correction can lead to the restoration of endometrial integrin. So if the patient does not want removal of tube, at least aspirate, do a neosalpingostomy so the liquid can come out through the tube rather than affecting the implantation. So the outcomes, when we say the hydrosalpinx and presence of hydrosalpinx is associated with significant lower implantation rates and pregnancy rates, spontaneous abortion rates have increased, and risk of ectopic pregnancies have increased, and embryos have reduced viability. So we have enough evidence to say that. So when we try doing a surgery for fertility, we have to ask ourselves, are we trying to do a surgery to enhance the spontaneous pregnancy, or are we trying to do the surgery to enhance the IVF outcomes? Means, are we doing a fertility preserving surgery or fertility enhancing surgery? What are we looking at? Because hydrosalpinx has a negative effect, we are looking at either lap salpingectomy, proximal tubal occlusion, lap neosalpingostomy, or Assure, which is no longer being used, transvaginal aspiration by ultrasound guided, or antibiotic treatment itself. If it is an acute PID, antibiotic treatment will help, but rest of the cases, antibiotic treatment is not going to help. But for chronic endometritis, antibiotic treatment throughout the pregnancy is something which is mandatory. So then we look at feasibility, the technique, clinical scenario. When is it feasible? Importance of other pathologies and age of patient preference. And nowadays we have the patients asking for natural procreation. They want to conceive naturally. I tell the patient there is nothing abnormal in the ova or the sperm. There's nothing abnormal in the egg or the baby which is being formed. We're only helping it form the baby. We are not creating the baby, the sperm, and that's all natural. There's nothing unnatural in baby formation. But here comes the insurance coverage. That's when the laparoscopy is covered, IVF is not covered. And the results of ART program, again, we are telling 50-50. And the realistic expectations are something we are looking at. So we can give the option of laparoscopy for them with the microsurgical principles of proper magnification, respect of tissues, meticulous hemostasis, avoidance of peritoneal desiccation, acute ovariosalpingolysis, and use of microsurgical instrumentation, least use of energy sources, and use of adhesion prevention techniques wherever necessary. So when all these criteria are respected, good results are obtained with a good pregnancy rate. So I want to show you two videos, one for the chronic PID, one for the acute PID. This is one of the acute PID case when we did the thing. And these are the tubes, if we are going to retain them and we are going to keep them, this will end up with chronic hydrosalpinges and end up with the pregnancy loss. In these cases, to preserve the fertility, the best option would be the salpingectomy. You can see we are doing with the least energy source, that is the harmonic. We are going to do the salpingectomy, and you can actually see the caseous pus coming out from the fallopian tube. Trying to retain such tubes and doing a salpingostomy. So here you can see how the pus is oozing out from the fallopian tube, and saving these tubes are more detrimental for these women. So salpingectomy is the way to go for this patient. And this patient, after an antibiotic treatment, had a pregnancy on the second cycle when we went ahead and gave the IVF treatment. Now, this is a patient who came from Uganda after undergoing the proximal clipping. You can see the clips here where the proximal clipping was done for the hydrosalpinges. Nothing was done. Then she came for a tourism here, ended up with acute pain abdomen, and she had a twisted hydrosalpinges. Why are we leaving the fallopian tubes with the heavy hydrosalpinges, allowing them to going in for the twist and having an acute pain abdomen? So do a salpingectomy. So I am in favor of salpingectomy than the proximal clipping, because you are allowing the liquid to stay. The liquid can actually come in the retrograde, falling on the ovary, affecting the oocyte also when you are retrieving the through the hysteroscope or transvaginal thing also. So with these things, I think depending on the severity of the disease, preserved mucosal folds, microsurgical technique of repair, hydrosalpinx, effect of salpingectomy is, if the ultrasound shows hydrosalpinx, remove it. If the ultrasound does not show, then you can look at opening the tube or the neosalpingostomy or the alternative treatment of clipping, where the liquid is not going to cause a heavy hydrosalpinx and the twist. So salpingectomy, the results are 57%. Proximal occlusion, the results take-home message is 46%. Definitely, I prefer to err on the salpingectomy technique, where it is better to remove the cause. The effect is going to be the best. So surgical treatment for hydrosalpinx is all the three interventions, that is neosalpingostomy, salpingectomy plus proximal occlusion, will help in IVF ET. But I think if a good surgeon is not there, they would go for something which is like clipping, because it is easy for them to do. But if you're a good surgeon, you should do which is the best outcome for the patient. So do a good salpingectomy closer to the fallopian tube using harmonic, so the vessel to the oocyte does not go. So the ovarian reserve is not gone. Using the bipolar and the scissor, definitely the vessel to the oocyte ovary will be gone and the ovarian reserve will go. But if you know what you're dealing with, this type of surgery and the technique of the surgery, you're not going to affect the ovarian reserve, and it is always a salpingectomy and the tubal occlusion which will have improved outcomes. Proximal tubal occlusion ranks highest for most of the people, because that's what all over world people have been doing. No differences were found in the outcomes of miscarriage and ectopic pregnancy in that. So the outcomes of IVF after neosalpingostomy is matchable with salpingectomy, but not for gross hydrosalpinx. But laparoscopic neosalpingostomy can be an alternative to manage moderate hydrosalpinx. My best thing would be salpingectomy, but I think individually, depending on what they're good at, to use the least energy source with minimal messing up of the tissues there, with giving respect to the tissue. We should be looking at surgical management of hydrosalpinx. It is beneficial, and the type of surgical management depends on the hydrosalpinx, the amount of the fluid we are looking at, and the proximal versus distal occlusion. So I truly believe in what Albert Einstein has always said, that the single light of science is to shine it to anywhere, is to shine it everywhere. And thank you, TNOG, and thank you, Vanita, for giving me this opportunity to talk today.
Thank you, madam, for the wonderful lecture. Elaborate as always.
I thought I just stuck to 15 minutes. I hope it was.
It was more than enough, Manjula. You have put it in a nutshell. And the main thing is when you don't see an hydrosalpinx in ultrasound, I think there is no need to go for a salpingectomy or a corneal block, because all of us would have had personal experiences, especially when operating for endometriosis. All these tubes will be mildly
swollen.
There will be evidence of swollen. So they are probably edematous changes or secondary to this endometriosis or that occurs during surgery. And invariably, if you leave it, the chances for spontaneous conception is quite good. So we need to decide for which patient you have to do salpingectomy and which patient you have to go for a conservative, like don't operate. But
one more point I wanted to add. When is a twisted ovary, we end up just untwisting and we know that fallopian tube comes back to normal function.
Yes, yes.
We have to understand when to operate. Chronic PID, hydrosalpinx, just remove the tube. Acute PID, you can still give antibiotic, untwist and leave them. Edema comes down and function is going to be good. But between the proximal occlusion with salpingectomy, doing a good salpingectomy, good surgery is the best way to go forward.
See, maybe proximal tubal occlusion, we do it when the patient has got a multiple previous surgeries where you find intense additions where you can focus only the conova, then maybe that time it is feasible. And the second one is there a role for hysteroscopic? We are not using Assure at all, but is there a role for cauterization or using a resectoscope in the carnova?
Even if you do, the opening you are not going to close. So here the hydrosalpinges, we are looking at the fluid coming into the endometrium. So it is all absurd. These are all theories people start putting it, but real life scenario is useless.
And more than that, we are going to damage the myometrium also. So this, I think this is a very valid point. And regarding the aspiration of hydrosalpinx, ultrasound guided aspiration of hydrosalpinx.
Madam, I have had enough share of patients coming from IVF center with pelvic abscesses. After why do you have to do that? I will never understand that point. So is why through the vagina, through the infection. First of all, it is a PID. First of all, it's an infection. You are going and putting a pathway from the infection to come from the fallopian tube to that.
So in general, any aspiratory procedures in the pelvis should be avoided. That will provoke more and more of pelvic inflammation. So that is the message. So Dr. Annie, do you want to add anything?
No, ma'am, because everything has been said and beautifully discussed and wonderful presentation, I should say. And really, we had very informative. It has been a very informative session, ma'am.
Okay, Dr. Annie. Thank you for giving me this opportunity.
Thank you, Manjula. Thank you.
May I take this opportunity to tell especially the juniors that Manjula Madam runs an educational group in WhatsApp. So any juniors, if you're really in need of any opinions, you post your question and I promise you the answer is there within a fraction of a second. So for the benefit of the juniors, they can use it.
It's called Dr. Manjula Nagani Edu Group. Anybody can put any question there and I'll give the answer.
So that is the best way of propagating knowledge, Manjula. Hats off to you.
Thank you.
Your knowledge should be shared.
Thank you.
Thank you.
Thank you.
Next speaker is Dr. Jaydeep Tang, the most beloved person of FOXY and a Secretary General of FOXY from 2018 to 2021. And he is a project lead of FOXY USAID program projects in 2020 to 2024. Past president of Mumbai Obstetric and Gynec Society, and he has held. He is holding so many posts: Deputy Secretary of TNFOG, immediate past chair of International Federation of FIGO's Committee for Safe Abortion, awarded honorary FRCOG in 2020 by Royal College, and then past chair publication and newsletter of EVAFOG, past chair Reproductive Endocrinology and Infertility Committee of EVAFOG, past chair MTP Committee of FOXY, consultant in Aswini Maternity and Surgical Hospital. And then he is a very good endoscopic surgeon and an IVF consultant. And more than that, he is a wonderful person. And my acquaintance with Dr. Jaydeep Tang is the period, I should say that it was a golden period. Only for the past 3 years, I know him. But I don't have any words to say about his gentlemanship. So I welcome you for this August meeting, sir.
Thank you. Thank you very much,
Good evening,
madam.
sir. Good evening, sir.
Hi, Dr.
Welcome.
Marian. Thank you. Thank you.
And all the best for your president election, sir. All the best.
Thank you, madam. I'll just share my screen. And
yeah.
Right. I hope my slide is seen. My first slide is the.
Sir.
Yes, sir.
So let me first begin by thanking Dr. Ramani Devi madam for that really very, very kind, warm, and very generous introduction. I had the pleasure of working, as madam said, as Secretary General with madam, and she was always such an approachable, such a nice and very prompt and enthusiastic Vice President to work with. It was a real honor and a pleasure, madam, working with you. And I hope that I can work with you again. Thank you very much also, Dr. Mary Ann, for co-chairing the session with her.
Thank you, sir. I'm really honored, sir.
Thank you. I'm so delighted to be at this TNFOG CME. And I must thank the organizers, Dr. Anjalakshi, Dr. Sampath Kumari, and Dr. Vijay Lakshmi for inviting me here. I must say that, you know, even at this level of seniority, Dr. Sampath Kumari was personally following up on every aspect of the CME. I think, madam, that's really remarkable. You didn't just outsource it to anybody, and you make sure that you looked after all the small aspects also personally. That's really very remarkable. Thank you so much. It is, of course,
Thank you, sir.
It is, of course, a pleasure to share the forum with Dr. Suchitra Pandit, who was the chief guest, and such eminent chairpersons for the first session, Dr. Chitra and Dr. Revati Madam, again, who I had the pleasure of working with in Foxy for some time. Very good evening to you, madam. And of course, we've had some fantastic talks from Dr. PG Paul, Dr. Murlidhar Pai, and just now from Dr. Manjula. And I must also thank the coordinators, Dr. Meenakshi and Dr. Vanita, for putting this whole program together. I am actually going to speak on a fairly, I would say, not very well discussed topic, which is prophylactic salpingectomy. In fact, if I'm not mistaken, this topic has actually come into focus only quite recently. But before I begin the presentation, I will request all of you here to please support me as I stand for the presidency of Foxy. A request I will be reiterating at the end of the presentation. In fact, I think perhaps that a lot of attention on prophylactic surgery came after this op-ed, which was written by the very famous actress Angelina Jolie, when she underwent a prophylactic bilateral mastectomy. And this happened way back in 2013. But I think the echoes of this decision to undergo a prophylactic surgery for prevention of cancer by such a renowned person, and also such a renowned person who was very willing to speak about it, are still being felt. Commentaries on her decision, merits, demerits, both medical as well as mental, and its impact on other patients, I think are still being discussed today. The Harvard Medical Journal, Harvard Medical blog published, Angelina Jolie made it to the cover of Time magazine with this disclosure. And I quite like the very balanced way in which the Harvard Health Publishing approached the issue, while recognizing the autonomy and the fact that decision-making about their bodies belong only to women. They also recognize the fact that perhaps the evidence at that point in time may not have suggested that this was the best possible way. After all surgery carries some risk or the other. And reconstructive surgery particularly sometimes results in lifelong disabilities. Now you may wonder why I'm equating mastectomy with salpingectomy. Admittedly, they are two very different procedures. But when you look at the context of why we started talking about prophylactic salpingectomy, it is easy to understand that one of the major reasons why we started talking about it was because we thought that it could prevent cancer. And I must say this, that we are perhaps the one field in medicine where we have a drug, the oral contraceptive pill, which can reduce the incidence of ovarian cancer. And we also have a surgery, which is prophylactic, ideally bilateral salpingo-oophorectomy, but even salpingectomy, which can reduce the incidence of a major cancer. So these are the talking points of the presentation. We'll talk about prophylactic salpingectomy in terms of prevention of cancer. Dr. Manjula has already spoken about it in IVF and infertility, so I'll just touch very briefly on that. We'll talk about why we need to change our approach in permanent sterilization and talk a little bit also about opportunistic or standalone procedures for prophylactic salpingectomy, and then wind it up with a few surgical principles as we perform prophylactic salpingectomy. The whole discussion around prophylactic salpingectomy and the role of the fallopian tubes actually came about because, of course, we know that ovarian cancer is the leading cause of death, and it is the high-grade serous carcinoma, HGSC, which is responsible for the large amount of morbidity and mortality, and we know that this generally presents at an advanced stage. It was way back in 2001 when a high rate of tubal neoplastic lesions and I will elaborate on that acronym here. There are so many acronyms nowadays. RRBSO, which stands for Risk Reduction Bilateral Salpingo-Oophorectomy, which used to be recommended largely at that time for women who were developed estrogen-sensitive breast cancer tumors. And there was a high rate of tubal neoplastic specimens which was discovered in them. And in these reports, when these were carefully analyzed, it was found that there were pre-invasive cancerous lesions. And then, of course, there was this unifying hypothesis by Crum et al. Which suggested that it was actually the fallopian tubes where a whole lot of serous ovarian cancers started originating. There was this conflation on whether it was truly originating in the tube or whether the ovary actually had some precursor lesions. And it was quickly established that these tubal intraepithelial carcinomas had actually nothing to do with precursor lesions. There was further support of this hypothesis when it was realized that there were highly similar cytological features and even molecular similarities between TICs and invasive high-grade ovarian cancers. In fact, it has now been hypothesized that perhaps it's the fimbriae, which are the most common place for precancerous and non-invasive malignant precursor lesions within the entire fallopian tube. Now that is knowledge of physiology and pathogenesis, which is invaluable because, for example, like at a sterilization operation, you don't remove the fimbriae, perhaps not complying with the principles of prophylactic salpingectomy for the prevention of cancer. But of course, does this mean that the ovary then does not have anything to do with the cancer? Of course not. The ovary does have something to do with the cancer. Most importantly, the ovary has a lot to do with the metastasis and the spread of cancer within the peritoneal cavity. and ovaries play an active role in the spread of these tumors, possibly through the hormonal milieu. So as I said, interest in prophylactic salpingectomy actually is quite recent. And if you look at this screenshot of a Medline search I did today for prophylactic salpingectomy, you will see that the number of articles which have appeared on this issue have actually peaked over the last few years. Therefore, we now have some evidence to suggest that prophylactic salpingectomy is a reasonable approach to take. What then do national societies advise? And I think this has always been an interesting study to me. What do guidelines advise across guidelines? What do national societies advise across national societies? And when this quite interesting study came out and they looked at the websites of 130 FIGO member societies, they found that from 130 societies, only 13 or 14 countries have statements regarding opportunistic salpingectomy. None of the statements opposed prophylactic salpingectomy. However, only a small minority of FIGO members have statements on opportunistic prophylactic salpingectomy, and there are some countries where the statements are ambulative or supportive. This, of course, influences physicians' practice, and in a knowledge attitude practice study which was carried out, it seemed that most physicians found it difficult to discuss and implement a change in care for patients because of the preconceived notions of ovarian preservation or removal, where we always say, don't remove the ovary unless the patient is postmenopausal or has a high risk for ovarian cancer. In fact, however, it would be fair to say that in the current state of affairs, the post-reproductive fallopian tube is probably better off removed rather than being retained, particularly for women above a reproductive age. Of course, does adding salpingectomy as an operation per se make any difference to the hysterectomy alone? The answer is no. The addition of salpingectomy as an operation makes no difference to the complication rates. And in fact, if you look at this Cochrane database, there really is no evidence for any difference in the onset of menopause after a hysterectomy with salpingectomy. If you look at data which is later after the Cochrane database, you will see that there is now good evidence to show that the incidence of ovarian cancer among women who underwent a prophylactic salpingectomy is quite lower compared to women who did not undergo the prophylactic salpingectomy. So then the question arises, who should undergo a prophylactic salpingectomy as a standalone procedure? I think we have now very well established that if she's undergoing any intervention, then it's a good idea to remove the tubes, particularly a hysterectomy, not the ovaries, but the tubes. But what about patients who are at otherwise high risk, as these patients were called in this article, ovarian cancer previvors? It's a fairly new word. I heard of it for the first time. And the essential question is this: how do you advise a young BRCA mutation carrier who has completed her family while still in her 30s or is in her 40s? This is a patient now who says, I don't want to undergo a risk reduction BSO. And then you would have to counsel her very carefully and explain to her the benefits of undergoing a risk reduction surgery, but at the same time also tell her about the evidence that surrounds this. You just heard a fantastic lecture on salpingectomy for hydrosalpinx, and in IVF, the concern really is always whether prophylactic bilateral salpingectomy reduces ovarian reserve. I think there is now good evidence to show that if you stay close to the fallopian tube or the mesosalpinx, don't remove too much of it so that the anastomosing vessels are not cut, you will find that there is no difference in ovarian reserve. When we do a prophylactic in a permanent sterilization, namely a tubal ligation, incidentally the most popular method of contraception in this country, we always tend to use the Pomeroy method or the loop, where we remove a small part of the middle segment of the fallopian tube. However, in view of the new evidence, which talks about removing the tube as a risk reduction strategy for ovarian cancer, we should now perhaps, after careful counseling, start thinking of doing bilateral salpingectomies. Of course, you need to inform the patients that once this is done, then the tube will be repaired back in case a further childbearing is needed. However, we need to start talking and start thinking about this. Opportunistic bilateral prophylactic salpingectomies, of course, need to be discussed, need to be talked about. And as this article says, for risk reducing salpingectomy, let us be opportunistic. Let us use every opportunity that we get when the patient has completed her family, for example, permanent sterilization, or even salpingectomy at the time of delivery, immediately postpartum, or at the time of a C-section. I think we need to change in the mindset where we move from removing only a small part of the tube to at least considering salpingectomy in some patients. It was very well established, Dr. Sirish and his team, that even while doing a vaginal hysterectomy, you could quite easily do salpingectomies. Oophorectomies sometimes could pose a challenge, but there have been enough evidence to show that even oophorectomy is possible in the large number of cases. So doing a hysterectomy through the vaginal route is not really any reason why you should not do a prophylactic salpingectomy. In fact, we need to start talking to our colleagues, urogynecologists, even general surgeons who perform laparoscopic cholecystectomies. A lot of lap cholecystectomies are performed usually between the age of 35 to 50. And even this could actually be used as an opportunity by the surgeon to perform a prophylactic salpingectomy for that patient as a risk reduction strategy to prevent cancer. I will end with a few surgical principles. At total abdominal hysterectomy, it's always a good idea to simply do a clamp, cut, and ligate. Rather than using fancy energy sources, you have an open abdomen there in front of you. You might as well clamp, cut, and ligate. The important thing, however, particularly in women who are not very close to menopause, is to make sure that the clamp is applied not at the infundibulopelvic ligament, but on the mesosalpinx directly, and make sure that you also remove the cornual end properly. Otherwise, she may land up with an ectopic pregnancy in the cornual part of the tube. At TLH, we generally prefer to do the salpingectomy at the end of the procedure rather than the beginning of the procedure. So we go in, we start with usually the round ligament, we cut the tubes, we complete the hysterectomy, and after the vault is open and the uterus has been delivered, we cut the tube and then just remove the tube through the vagina. The reason we prefer to do this is that if you remove the tube and leave it hanging on the uterus, on the specimen side, it will keep on coming in your way when you're trying to go below the cornuals and getting the uterine or the uterosacral, etc. And of course, at vaginal hysterectomy, the one thing I'd like to say is that don't pull on the tube too hard. Because if you pull on the tube too hard, sometimes by the time you have reached the area of the cornuals, there has been a certain amount of mesosalpinx that has been cut. And if you pull too hard, that mesosalpinx might get avulsed. If that gets avulsed, you'll find that the tube comes into your hand, and then it is quite difficult to control the bleeding because the vessels in the mesosalpinx are trapped. So at a vaginal hysterectomy, if we are doing a prophylactic salpingectomy, what we do is we take the round ligament in the cornual part separately. Once you take the round ligament separately, it will go back up and you will see that the tube is immediately in front of you. You can then easily hold the tube with the backcock and then clamp it. Remember to hold the tube with the backcock and then clamp it so that even if the clamp slips, you have the tube held with the backcock and you can hold the mesosalpinx again easily. As a standalone surgery, we haven't really done too many only salpingectomies. We have done quite a few salpingo-oophorectomies for women who have got estrogen-dependent breast cancer, where the surgeons send the patients to us for doing a risk reduction bilateral salpingo-oophorectomy. And here, if it is going to be a standalone surgery, the only thing I would say is that please try and remain as close to the tube as possible. Don't cut too much of the mesosalpinx, otherwise you will compromise the blood supply to the ovary. So let me end the presentation by saying a milligram of prevention is worth a kilogram of cure. And a prophylactic salpingectomy indeed is a milligram of prevention when you compare it with the consequences of not doing it. Let me at the end again reiterate and request everyone to please support me as I stand for the presidency of FOXI. If you're watching this on your laptop and you have a mobile, you can scan the QR code
I'll
on this.
just call you after 5 minutes. I'm chairing a session.
You can scan the QR code. It will take you to my website. And once you're on the website, you can register your support for me. And I'm so humbled, honored, and thrilled to share that literally thousands of Foxians have already registered their support for me. There is a video blog section on the website, which has a lot of my old presentations. And there is a link to join a Telegram channel where I put up whenever I'm making a presentation over the web. Thank you very much again, TNFOG, for having me here. It's always such a pleasure and privilege to be here. And I must thank again the office bearers of TNFOG, Dr. Anjalakshi, Dr. Sampath Kumari, and Dr. Vijay Lakshmi, and the chairpersons of my session, Dr. Ramni Devi Madam and Dr. Mary Ann, for having me here. Thank you very much.
Thank you, sir, for the nice talk, and my best wishes for your success, sir.
Thank you. Same to
Really,
you.
sir. Thank you so much for the beautiful, illustrative, and evidence-based talks. Earlier, we had been so much about prophylactic oophorectomy. Now we are again for prophylactic salpingectomy, and the role of prophylactic salpingectomy in vaginal hysterectomy and standalone surgery. You really did give us a very beautiful information, sir. That was really good. And we promise to support you for your presidentship and will be there with you with full support. And advance congratulations, sir. Thank you so much, sir. And I thank the TNFOG team and the FOXI for giving this wonderful opportunity. And I see Marathon series has been gaining more of attraction nowadays, and it has been really a very, very useful program for the postgraduates as well as all of us. So thank you once again, everybody here, my seniors as well as my friends.
Ma'am, we have a question in the chat box, Jaydeep, sir. The question is, in vaginal hysterectomy, if we happen to remove only the fimbrial end, what is the chance of a hydrosalpinx by Dr. Shilpa, sir?
Thank you for that question. But really, I mean, if you're doing a hysterectomy, why would you remove only the fimbrial?
Yeah. In vaginal hysterectomy is what she has put it. So maybe if you're not able to access or
very unlikely. If you can access the fimbria, you can normally access the entire tube. In a vaginal hysterectomy, the fimbria comes at the very top. It's not like an abdominal where the tube is, equally approached. So if you can get the fimbria, you'll be able to get the whole tube. Having said that, in the rare occasion when you are removing only the fimbrial end, not a recommendation, mind you, but if you are doing that, then there are significant chances of hydrosalpinx. And I would really advise you not to do that.
So sir's answer is either remove it in toto or just leave aside, not cause harm to the patient in terms of a hydrosalpinx.
Yeah, but one of the more important message is that you will always be able to remove it. Yes. In all these years.
Especially we have special clamps designed by Piley sir and all that, which really help us to walk over the tube and get access to them. Sir.
It is actually a block to not do a prophylactic salpingectomy at vaginal hysterectomy. It's really not that difficult.
So we like to have Jaydeep sir physically in Chennai.
Yes, ma'am.
Now we are having Dr. Jaydeep on 16th at Trichy physically.
Yes.
We are expecting your presence, sir. Eagerly, all the Triaxians are expecting your presence.
Thank you, madam. I'm looking forward to being there and celebrating Foxy Friendship Day.
That day we are planning for Foxy Friends Day also, day celebration also.
Foxy Friendship Day, what?
Yes, madam. 14th is Foxy Friendship Day. But since sir is available on 16th, we thought we'll celebrate on 16th.
It's
Oh,
an
I will
excellent
arrange
friendship
one,
week, ma'am.
Jaideep sir, I will arrange one program on 17th in Chennai from TNFOG.
TNFOG and Foxy Friendship Day.
We will try. Okay.
Excellent friendship.
Yes, Anita, you can give the vote of thanks.
Yes. It gives me privilege and pleasure to come to propose the vote of thanks on behalf of the organizing committee of TNFOG Marathon Series on Only Tubes. I take extreme pleasure in thanking Professor Suchitra Pandit, who is the past Foxy president, who accepted to be the chief guest and grace the occasion. I also thank the chairpersons, Dr. TV Chitra, Dr. Revati Janakiraman Madam, Dr. Ramani Devi Madam, and Mary Annie Madam, who also spent their time with us, graced the occasion, and made sure they kept us comfortable and the speakers comfortable and sharing their views and thoughts on the topics. It is my extreme pleasure, privilege, and honor to thank the speakers, eminent esteemed speakers, Dr. Muralidhar Pai, Dr. Paul Sir, Dr. Manjula Madam, and Jaideep Tan, who are renowned in their own specialities, who took time off their busy schedules to be with us, to share their knowledge with us, and enlightening us. Thank you one and all. And I also take this opportunity to thank the media partner, Shield Pharmaceuticals. This brings us to the end of this marathon CME. Thank you one and all. And a special wish to Jaideep. Thanks, sir, for his forthcoming elections. Wishing to see you as the Foxy president with a thumping victory, sir.
Thank you. Thank you so much.
Jaideep sir, once you become the president-elect, first meeting will be for TNFOG.
Madam, advance booking. Okay,
thank you.
Sir always likes to be in Chennai as much as what he saw first AIC was with Talapati.
Anita, now only TNFOG is on my hand. So I am telling on TNFOG.
Now we will have Vijay movie release for you, sir. Beast.
Yes, we'll make one. Or the Talapati will be what to tell, a remake of Talapati.
Lovely.
Thank you, sir.
Okay. Thank you. Thank you, sir.
Thank you, sir. Thank you, ma'am. Thank you, everybody.
Thank you, everyone.
Thank you, Sambat ma'am. Thank you, Anjalakshmi ma'am, and everybody here. Thank you.
Thank you, Revati, Ramani, Jaideep sir, Vanita, Meenakshi.
Thank you so much, ma'am.
I nominate Dr. Mary Annie also. She is not asking on her behalf. I am asking. Nominate her for Medical Education Committee, and Jaideep Tank already nominated. Okay, thank you.
Ma'am,
Thank you, madam, for supporting me so much. Thank you, really.
Thank you, thank you. Thank you, sir.
Thank you, ma'am. Thank you.
Yes, madam, we can leave, I think.
Thank you, Sambat ma'am.
Thank you, ma'am.